Thank you so much, Dr. Guntupalli. I'm so honored by your invitation and your friendship over the years. Good afternoon, ladies and gentlemen. It's a distinct honor to be here. The lovely part about coming to the CHESS meetings is I meet some of my former attendings, Don Craven, just a few minutes ago, and I also have the great pleasure of meeting many of my former students and my trainees. So it's a great honor to be here. I've picked a title today that's deliberately a bit provocative, and I hope that you will indulge me as I make my case. My talk is entitled, Percussing the Chest in the Era of Homo Technologicus. And I wonder if you would just bear with me as I ask you to engage in a little bit of fantasy. I want you to imagine that in the year 2010, an alien arrives in America. I can only speak with some authority to America. And as you all know, aliens look just like this, and that's why I've put up that image. This is an evidence-based observation, so if you Google alien, this is what you will get. An alien arrives in one of our American hospitals and decides, because this is an academic alien in medicine, to observe what we do in internal medicine teaching programs. And the alien stands in a corner on the ward and over the course of a couple of weeks makes some observations about the practice of medicine. And this is what the alien observes. First of all, rounds seem to take place in a room that is generally removed from where the patient is. The alien also observes that most of the activity seems centered not around the patient, but around the virtual construct of the patient in the computer. And I have coined the term the eye-patient to refer to that entity. You know, like your iPad, your iPhone, we have the eye-patient. The alien observes that the patient in the bed is a mere icon for the real patient who's in the computer. And the alien also observes that the bedside is generally toxic to the physicians, and most people avoid it, but some older physicians evidently did not get the word, and so they spend inordinate amounts of time at the bedside. And ultimately, the alien concludes that the objective of a medical admission is to render the live patient in his or her three-dimensional glory into a two-dimensional image that can be stored in the computer. And the question that the alien asks, and we should probably ask too, is how did we humans arrive at this point in medicine? And in the next few slides, I hope to try and address that. For some of the trainees in the room, it might surprise you to know that the moment in time when we began to start looking into the body, being able to diagnose what was going on in the internal organs, it's a very, very recent moment. It did not happen with Hippocrates. In fact, I would date it to the lifetime of Joseph Leopold Auenbrugger. Auenbrugger was a physician, but he happened to be the son of an innkeeper. And when he became a physician, Auenbrugger recalled that as a child, his father would take him to the cellar of the inn, and they would try and determine how much wine was left in these big wooden casks in which they stored the wine. And his father would pound on the side of the cask until he arrived at a change in note, which was where the meniscus was, and by this means the father was able to say when they should reorder the wine. And Auenbrugger took this information and carried it with him, and when he became a clinician, he applied that to the human body, especially to the chest. And he wrote this wonderful book titled Inventum Novum, New Invention. And ladies and gentlemen, everything that we know about percussion, Auenbrugger pretty much covered in that book. It really was an incredibly important moment in medicine, especially in chest medicine. Unfortunately, no one picked up on Auenbrugger's observations, and it would have gone completely ignored but for this gentleman, Corvisart, who was Napoleon's physician. And Corvisart, unlike Auenbrugger, was a very, very famous physician with great influence, lots of authority. And Corvisart picked up the manuscript of Inventum Novum, tested it out for about 20 years, and just before Auenbrugger died, Corvisart reintroduced the work with a French translation and his own introduction affirming that this was useful, and percussion finally arrived. Percussion was quickly taken up by the French, who were the masters of clinical exam at that moment. And I want to mention in passing Pierre Piori, who invented the pleximeter. It might surprise those of you who still percuss to know that percussion was done by placing that object, a pleximeter, on the patient's body and then tapping on it with a little hammer. In fact, our present reflex hammer has its origins in the percussion hammer. And we gave up the pleximeter and hammer because we realized that what was much more relevant was not just the sound, but also the feeling coming back to the pleximeter finger. So stony dullness is much better perceived with your finger than with a pleximeter. But an anecdote about Pierre Piori: he would sit on a stool and he would percuss his patients and he would draw on them. He was like the Paganini of percussion, and he carried it to great extremes. He was once seeking an audience with the King of France. He must have been a pretty annoying person, Piori, I mean. And so the King of France sent word to tell him that the king was not in the chambers. And Piori is said to have percussed the chamber door and said, "The king is in his chambers." And shortly thereafter came auscultation by Corvus art student Laennec, from this famous painting that you see, demonstrating Laennec auscultating directly, but in his hand is the instrument which became the stethoscope. And all of a sudden, not just percussion, but auscultation had arrived. And this was an incredibly huge moment in medicine, a quantum improvement on the barber surgeon. Just to remind you, until that time, no matter what ailed you, diarrhea, cough, fever, you would go to the barber surgeon and he would cup you, purge you, bleed you, no matter what you went in for, which, by the way, is what some people would say happens even now when you go to the emergency room. No matter what happens to you, you're going to get your spiral CT, your cardiac enzymes, and your blood cultures. A very similar sort of experience. But this discovery of percussion and auscultation represented a departure. Someone was going to start asking, what is going on, and where is it going on, and what does it involve? It was a very important moment in time. For the trainees in the room, I should point out, if you don't already know, that this very famous icon of a barber shop has its origins very much in the barber surgeon's occupation. They would collect the blood in this basin. The patient would hold on to a pole, and a tourniquet would be applied, and then they would slice the vein to bleed the patient, and the red and white represented the bloody rags that were washed and hung out to dry. And a nice reminder of our very recent origins. Now, I want to share with you this picture, this painting by Luke Fields called The Doctor. This is this is the most famous painting in medicine. It is without a doubt the most famous and iconic medical painting. It is called The Doctor by Luke Fields. It is hung continuously in the Tate Gallery. And it's an interesting painting because it has a lot of story behind it. Luke Fields was an extraordinary painter. He developed his reputation. And Tate, who was about to build this big gallery called the Tate Gallery in London. How many of you have been to the Tate Museum in London? A wonderful show of hands. And those of you who go to London next shouldn't miss it. It's a wonderful gallery. Tate commissioned Luke Fields to paint something of social importance to hang in his new gallery. And Fields decided that his topic would be to portray the doctor in his time. And we're talking about the late 1800s. And Fields was very moved by an event that happened on Christmas Eve of 1886 when his son Philip, 9 years old, succumbed to a short illness. And Fields was most impressed with the doctor who had held vigil for 2 nights and days over his son. And so when he was asked to render this painting, he spent the several years painting this scene that you see before you. And I just want to lead you through this, if I may. As you can see, the painting is dominated by the figure of the child in the center. This is clearly a child who otherwise would be sleeping on a straw pallet in the back of this fisherman's cottage, but because of the illness is sleeping on 2 dining chairs drawn together. On one side are the parents, looking on very anxiously, the mother praying. On this side is the physician, looking on very, very attentively. And even though this is now the era of the stethoscope and percussion and the ophthalmoscope and the laryngoscope, it's very interesting that Fields decided to portray this doctor with none of those tools, nothing but his attentiveness. And this painting really struck a chord with the general public. When Fields was asked what this painting represented, he never mentioned his son or his son's death. He said that this painting is about dawn breaking and sunlight coming through the window and hope arriving, hope that must never be extinguished for any of us. That was his explanation. Now, this painting went on to have so much acclaim. It was on postage stamps all over the world. It was infamously used by the AMA in their wonderful campaign to undo Truman's proposed socialized medicine, which Truman trotted out in 1952. The AMA printed 60,000 of these posters. If you ask your patients of a certain age, they will all recall seeing these posters in their doctor's office. It had words on them such as, "Keep politics out of this picture," or "Don't let the government take the doctor out of this picture," as though the success of the AMA is such that we are now all in this picture, constantly making home visits, aren't we? Nevertheless, it was a painting that was applied in many, many different ways. People have often asked, what is the painting about? And there have been PhDs and theses written about the painting, and everyone seems to focus on the doctor. And after all, that is the title of the painting. But my own thesis is that we respond to this painting not because of the doctor, but because we identify with this person. We identify with the patient. We picture ourselves being the patient, and the kind of physician we would want caring for us is someone capable of this kind of singular attention and attentiveness. To me, it calls to mind a line in the New Testament, "I was ill and you cared for me." Very simply, that is to me what I think the painting is about. And I've often wondered if Sir Luke Fields were alive today and someone challenged Luke Fields to paint a portrait of the doctor in our time, what would that portrait look like? And I am concerned, and I think many of you in this room share the concern, that increasingly rounds look very different than they did many, many years ago. I had the great privilege of training with Don Craven, who's sitting in the front row, at Boston City Hospital, and getting to see Maxwell Finland making rounds. Not making rounds, actually by then he was more than retired, but he was there, would visit. But this is a picture of the great Maxwell Finland of infectious disease fame, making rounds, and some of the people at the bedside include Morton Schwartz, who went on to be Chief of Infectious Disease at the Mass General, and Don might know some of the other names. But my point is this, that the rounds centered around the patient, whereas rounds these days can take on a very, very different look. And the question I have is, does it matter? Does it matter that this ritual has been substituted by this ritual? And aliens, by the way, are very familiar with rituals, and they are unwilling to lose their rituals. And should it matter that we're losing an important ritual? Since going to Stanford, I've had a great opportunity to talk to anthropologists and get to know folks in the anthropology department and talk to them about my interest in the bedside exam. And I shared with them an anecdote that I'd like to share with you, because it really is at the heart of what has moved me in this particular direction. When I was in Texas, in El Paso actually, at Texas Tech University, I developed a reputation as being interested in patients with chronic fatigue. Now, ladies and gentlemen, this is not a reputation you would wish on your worst enemy. I don't quite know how it happened. One patient led to another, and pretty soon I was seeing a fairly steady number of people with chronic fatigue. And I realized very early on, with maybe my first patient, that I could not do justice to this patient in a 45-minute new patient visit. These are patients who have been rejected by their families, who have felt rejected uniformly by the medical establishment, and they come to you quite prepared for you to join the line of rogues who have rejected them and treated them poorly. And I realized that this was just not going to work to see them in the usual fashion. And so I gave them 45 minutes, the new patient visit, entirely to tell me their story. And I did it without interrupting them. We are told that the average American physician interrupts their patient in 14 seconds. And if I ever go to heaven, it'll only be for the reason that I held my peace for 45 minutes and did not say a thing as the patient was allowed to tell their story. And I scheduled the physical exam for 2 weeks hence. And when the patient came back for that exam, I now had all kinds of time to do a very detailed exam. I like to think that I do a thorough exam anyway, but in that setting, since the history was now covered, I did an extremely thorough exam invoking every unnecessary neurologic and orthopedic maneuver I could think of just to occupy that time. And I remember my first or second patient, this very voluble patient, had not stopped giving me history, even though we'd agreed that this was no longer history, this was physical exam. But this patient kept talking, and somewhere along the way, I remember this patient becoming very quiet. And I had a very eerie sensation that I will never forget, that somehow the patient and I had slipped back into a primitive ritual in which I had a role and the patient had a role. And as I continued the exam, my awareness of this continued to increase. And when I was done, the patient said to me with some awe, "I have never been examined like this before." Which in a way is a condemnation of our medical care, because this patient had seen any number of people before this. And once the patient got dressed and came to my office, I wound up telling the patient exactly what they had heard everywhere else, which is, this is not in your head. The good news is this is not cancer, it's not coccidiomycosis, it's not histoplasma. The bad news is we don't know exactly what causes this, but here's what we should do. And I would trot out exactly what they had heard in other institutions. And I always felt that if they gave up the quest for the magic pill, the magic test, the magic doctor, and if they embarked with me on a course of trying to get back to functionality, it was only because I had earned the right to tell them these things by virtue of the physical. And it made me very interested in the whole phenomenon of ritual. Now, rituals are all about transformation. We baptize to signal a transformation, a crossing of a threshold. We have bar mitzvahs to signal this sort of a change. We marry with great expense and ceremony to signal our departure from a life of loneliness and solitude and misery to one of eternal bliss. I'm not sure why you're laughing. That was the intention. So rituals are all about transformation. I would submit to you that the ritual of one person coming to another and telling them their deepest, darkest secrets that they would not tell their rabbi or their preacher, and then even more incredibly, disrobing and allowing touch, I would submit to you that that is a ritual that's extremely important and that we cannot shortchange without great, great cost. Let us just examine the ritual as a craft. If we compare it, for example, to these extraordinary series of photographs that I was privileged to stumble onto of an Indonesian ceremonial sword maker teaching this skill to his son, in many ways the very skilled bedside art, as all of you know here, is in danger of extinction. The people who can teach it are getting grayer and more bent over and losing their hair, and the people who do it very well are fading. So this is a craft that is in danger of extinction. It has stable characteristics, but if it's not valued, it passes out of practice and dies. And let's compare our craft to the Indonesian sword maker, if we may. There is an apprenticeship. We call it the clerkship. In the clerkship, the student practices doing history and physicals. They model the behavior of the teacher. They use the tools the master carries, the ophthalmoscope, the tendon hammer. Of course, they model bad things too. If the master doesn't carry any of the tools, then the student is unlikely to start carrying them around too. In fact, I have great objection to the stethoscope draped around the neck as the solitary instrument that's taken around. To me, I always think that that stethoscope around the neck is not a signal of anything but your marital prospects. They just signal that you have cows and property and you should be considered someone worthy of a marriage proposal. They don't convey to me any confidence about your ability to examine the heart or the lungs or anything like that, especially if that's all you carry. We have a special terminology, just like the Indonesian swordsman. We know how to take observations and make them into words like fremitus and bronchial breathing and so on. The language is full of Latinate terms, so it's impenetrable to outsiders. And we even pick up from the master ways of talking to the patient. Open your mouth and say, this won't hurt at all. All the things that you think about that you wind up saying, you model somebody saying them. That's how you got to them. We have a very special place where this takes place. It's curtained off. We wear symbolic clothing. We hand the patient a special piece of clothing. There is mystery and potence. And as I mentioned, the patient accepts disrobing and touch, which in any other context would be assault. So I said that rituals are about transformation. What is the transformation that accompanies the bedside ritual? I would submit to you, and by the way, this is William Osler doing an examination, that the ritual, the transformation is as follows. It reveals signs hidden to the patient and the physician. I tell my house staff that when we examine the patient, we're looking for phenotypic markers of disease. And to me, it's an egregious error to miss a phenotypic marker of disease, such as, say, an example I heard recently from a colleague in Minneapolis of a patient who had shoulder pain and wound up seeing orthopods, getting MRIs, getting this, getting that, and finally stumbled onto one exam that seemed to show a slice of lung where there was an apical tumor. But the embarrassing part is this. The patient was walking around with clubbing for 2 or 3 months preceding that, and tender wrists and tender ankles, not just the shoulder. This was hypertrophic pulmonary osteoarthropathy, and at the very least, the patient could have been prevented from getting all those tests. So the transformation is revealing signs hidden to patient and physician. Touching the patient in this manner affirms our connection, our commitment to the patient. It generates trust. It establishes a bond. It validates the patient's complaint by taking the abstract complaint and focusing it on the body and affirming the body as the locus of personhood and disease. And each exam earns one the right to advise, to guide, and instruct. At Stanford, I'm struck by the fact that almost every patient winds up seeing in the hospital at least 20 different people, physicians. If you count the medical students, the consult teams, the different specialists who come by, and it's very, very hard for the patient to keep everyone straight. And my name has many syllables, very difficult to remember my last name. But very often the patient will say, I want to see that doctor, I don't remember his name, but the one who examined me so carefully. Clearly to the patient, this is meaningful. This is worth remembering. So, what can we do to preserve the ritual? I'm going to close by telling you something that we're trying to do at Stanford that might be of interest to some of you who are teachers in this room, which I think is most of you. We decided that it was a shame that physical diagnosis was taught in the first and second years of medical school when the student is really not engaging with the patient. And the moment the student arrives on the wards, physical diagnosis is no longer being taught, nor is it being taught in our residency program. And so we came up with something we call the Stanford 25. And for those of you who are interested, you can go to this website, the stanford25.wordpress.com. We were getting an average of about 100 hits a day, but when as Kay mentioned, the New York Times came and did the story on it and mentioned the website, we got 50,000 hits a day, and it sort of stayed in the thousands number. So, but I want to tell you right away that the website is not the Stanford 25. The Stanford 25 consists of hands-on teaching sessions where we teach the students and the interns and the residents one technique and have them show us that they can do it, and then have them show us that they can teach it. That is a Stanford 25 session. And to give you an example of what that might be, what is a Stanford 25? Number 2 or 3, I believe, is the ankle reflex in a bedridden patient. Now, I have the privilege of visiting hospitals and medical schools, and I'm often taken on rounds. And I will often, as a way of gauging what's going on, I will often ask the chief resident to demonstrate to me how they do the ankle reflex in a bedridden patient. And about 40% of the time, no one is carrying a knee hammer or a tendon hammer. And it makes you realize that the stuff that's in the electronic medical record about reflexes being intact and so on are really a form of fiction. And I love fiction, I write it, but the medical record is not the place for it. In fact, we just wrote an editorial called The Bedside Exam and Other Forms of Fiction. It just came out in the Journal of General Internal Medicine. But you know, to do an ankle reflex in a bedridden patient not just requires a hammer, but it requires positioning the patient just so and getting them to relax, striking the tendon just so with a hammer with sufficient weight, and I don't like the Taylor hammers, we confiscate those when we see them. And I think that this technique helps students and interns appreciate that technique matters. They can't just read Bates and assume that they can go and do it. They realize that it's nuanced, and we hope that it raises their awareness of all technique. And by the way, just to show you that I'm not a Luddite, number 25 is bedside ultrasound. I don't think there's any reason for us not to use the best of technology, but we need to do it at the bedside, not shipping people off here and there, but doing it as part of our extension of our interest in the welfare of the patient at the bedside. I'm going to close with this statement, which I hope that you will take away, that the ritual is important because without that ritual, we miss obvious things. We have become very focused on the kind of medical error where, you know, you cut off the wrong leg, you give the wrong medication. But ladies and gentlemen, you and I know that there are many other kinds of errors that are taking place that come from sloppy history taking, that come from missing obvious physical findings and submitting people to contrast and radiation that they don't need. I make a practice of collecting the phrases that people use to complain about doctors. And the number one phrase is, he or she never touched me. He or she never laid a hand on me. And when the New York Times article came out, it was interesting. We got so many letters from patients, all of whom clearly are saying this is important. And I got a lot of letters from physicians telling me this is not important. And I've actually wanted to write an op-ed to point out that there's a big disjunction between our understanding as a profession of what the patient needs and the patient's clear understanding of what they need. So I will close with this statement: the patient and the family can tell. Thank you so much for being so very attentive, and I think we're entertaining questions.